This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara. Today we're looking at a fascinating new study from the Journal of Neurosurgical Sciences, published in 2026. It's a systematic review and meta-analysis titled Decompressive Craniectomy for Spontaneous Supratentorial Intracerebral Hemorrhage.
It's a timely piece, Alara. Spontaneous supratentorial intracerebral hemorrhage, or SSICH, remains one of the most daunting challenges we face in the neuro-ICU. As the paper points out, it is a severe neurological condition associated with high morbidity and mortality. Even with our current protocols, managing these patients often feels like we're fighting an uphill battle.
Exactly. And the authors highlight that SSICH poses significant challenges to clinical management. While we have various therapeutic strategies at our disposal, the question of whether to take a patient to the OR for a decompressive craniectomy, or DC, is often a point of heavy debate during rounds.
Right. We've seen DC become a staple in other areas. The abstract mentions that its benefits are better established in some conditions, specifically citing traumatic brain injury, or TBI, and more general cases of spontaneous ICH. But when we narrow the scope specifically to supratentorial hemorrhages, the waters get a bit murkier.
That's the core of why this meta-analysis was conducted. The paper states that the specific role and efficacy of DC in the treatment of SSICH remain uncertain. This uncertainty creates a lot of variability in how different centers approach the same clinical picture.
And that's a problem for residents and attendings alike. We need evidence-based guidelines. The study aims to synthesize the available evidence to evaluate the impact of DC on clinical outcomes. Ilara, walk us through the primary intervention they were looking at.
The researchers focused on the impact of decompressive craniectomy, either performed alone or in combination with best medical treatment, which they refer to as BMT. They wanted to see how this compared against BMT alone, to determine if the surgical addition truly moves the needle on patient recovery.
It's an important distinction. We know that DC is employed to reduce intracranial pressure and prevent secondary brain injury. That's the physiological rationale. By removing a large bone flap, we're giving the brain room to swell, theoretically mitigating the catastrophic effects of intracranial hypertension. But the secondary brain injury in SSICH isn't just about pressure. It's about the neurotoxic effects of the blood itself and the inflammatory cascade.
Which is why the uncertainty the authors mention is so critical. In TBI, the pathology is often diffuse or related to external force. In SSICH, we're dealing with an internal vascular event. The meta-analysis was designed to see if the reduction in intracranial pressure provided by DC actually translates into better clinical outcomes for this specific patient population.
For our residents listening, it's worth noting the methodology here. By conducting a systematic review and meta-analysis, the authors are trying to pull together all the disparate data from various trials to give us a higher level of statistical power. They are trying to synthesize the available evidence because individual studies might be too small or too varied to give us a definitive answer.
And that's the hurdle, isn't it? If the role of DC remains uncertain, it's because the data hasn't been unified until now. For a practicing neurosurgeon, the decision to perform a DC is often a rescue move. We're looking at a patient who is declining despite best medical management, and we're asking, will a craniectomy actually save their quality of life? Or are we just decreasing mortality without improving morbidity?
That's the morbidity and mortality balance mentioned right at the start of the paper. If the condition is as severe as they say, we need to know if we are truly helping the patient or just changing the nature of their survival.
The study specifically looks at clinical outcomes, which is what our listeners care about most. It's not just about whether the ICP numbers on the monitor look better. It's about how the patient is doing 3 or 6 months down the line.
It's a high-stakes call. Every time we decide to proceed with a DC, we're considering the risks of the surgery itself against the secondary brain injury we're trying to prevent.
In summary, this 2026 paper from the Journal of Neurosurgical Sciences sets the stage by acknowledging that while DC is a known tool for TBI, its application in SSICH is still being defined. They've done the heavy lifting of synthesizing the evidence to help us clear up that uncertainty.
It's essential reading for anyone managing these patients in the acute setting. We'll be diving into the specific data points in our next segment. Thank you, Dr. Alara.
Thank you, Dr. Aris. Stay tuned as we continue to break down the latest in neurosurgical research.